Hospital. Um, Phil is really a world leader in the assessment of myocardial performance in premature infants throughout the first year of age. He actually pioneered and led on the research in the assessment of the right ventricle from the early newborn period throughout the first year of age, and has really set the standard worldwide for the reference ranges of a variety of measurements that we can use to assess the right ventricle. He's also part of several research consortia that look at the long-term outcome of infants with premature infants with chronic lung disease and other conditions. And he's also a very dear friend, and we collaborate together a lot. So without any further ado, I'll hand over to you, Philip, and I look forward to hearing your talk, which is titled Pulmonary Hypertension in Preterm and Term Neonates.
Thank you, Afif, for that lovely introduction. And it's great to be with everybody here tonight or today, wherever you're listening. I have no disclosures. I hope over the next kind of 45 minutes or so, we're going to have an opportunity to talk about pulmonary hypertension in term and preterm infants, looking at the pathogenesis, classification, talking about the hemodynamic profile. We'll then move on to looking at some clinical and echocardiographic markers to help diagnose, and then recognize some appropriate management strategies, and potentially end with some case examples and special considerations. So just in the way of just some background and review, I just put up two recent articles from our group looking at these specific questions, and you can refer to these articles for any more in-depth discussion. So what is pulmonary hypertension? I like to think about it in terms of mean pulmonary artery pressure, and some new guidelines have suggested when the mean pulmonary pressure is greater than 20 millimeters per mercury as diagnosed by cardiac catheterization. But I like to think about it in terms of an assessment of PVR, pulmonary vascular resistance, pulmonary blood flow, and pulmonary capillary wedge pressure, looking specifically at left heart disease. So this is going to be the theme of the focus for the talk, looking at these three features. The gold standard, as I mentioned, is cardiac catheterization, but in neonates, our first line screening is really echocardiography and clinical assessment. So just some incidence and epidemiologists, this is really changing right in front of our eyes over the last 5-10 years. Term infants, it's about 2 per 1,000 live-born infants in the US and a little bit larger range in the UK. When we talk about the preterm infants, there is early evidence of pulmonary hypertension in up to 8% of preterm infants, but more commonly in the early RDS patients. And then some newer information that has really kind of come out of the work that Dr. Al-Khafash has done with his cohorts in Ireland is even the incidence of pulmonary hypertension in neonates with Down syndrome was once thought to be as low as 5%, but is really now as high as 28 to 34%. And similarly, we and other groups have started to look at kind of the incidence of late pulmonary hypertension in preterm infants. And we've recognized that it can exist in up to about 40 to 60% in those preterm infants who have severe BPD. But you can see there's a range. Infants with moderate BPD have about 12%. And even infants with no evidence of lung disease could have somewhere between 2 and up to 6%, as high as 14% in some articles, of having late pulmonary hypertension. So the incidence is really evolving right in front of us. So the classification of neonatal pulmonary hypertension, I like to think about it in terms of term and preterm, and there's early and there's late. The traditional terminology has been persistent fetal circulation. That's an old term from the 1960s, but it's really now persistent pulmonary hypertension of the newborn. And when we look at the preterm population, there's early or acute and late, which is either chronic or persistent. And the terminology is acute pulmonary hypertension, and the late is defined as chronic or persistent pulmonary hypertension. This we usually see greater than 1 month of age. Now, just kind of taking a step backwards, it's important to understand the embryology and the origin. So most of us are familiar with airway development listed here on top, But it's fascinating that cardiac morphogenesis, specifically the right ventricle, actually evolves before the airway development in the embryonic stage. And the pulmonary vasculature arises from both a temporal and spatially controlled process that's linked both to the heart and the airway development. What's even more fascinating is that when we look at the development with the folding and the unfolding of the cardiac morphogenesis, we can see that the right ventricle and the pulmonary outflow tract, highlighted in blue, are linked to the same second heart field. So even though there's a clinical representation when we have the right ventricle and pulmonary vasculature, it's all linked back to development, embryology, and even genetics. Furthermore, when we're trying to piece it all together, we're trying to understand the relationship with the fetal circulation to the postnatal circulation. What I've shown here is just a diagram of the heart. We have oxygenated blood that leaves the placenta and has three pathways to get back to the placenta. It can go through the patent foramen ovale, pathway 1. It can go down the right atrium, the right ventricle, go through the pulmonary artery, and then through the ductus arteriosus, pathway 2. And then we know about 5 to 10% will actually make its way to the lungs, which has high pressure, and make it back to the left side of the heart. Now, when the babies are born and they take their first breath, you lose the placenta, you lose some of the ductal connections, both the PDA, the PFO, the ductus venosus. So I like just straight up pictures where you could have the right atrium, right ventricle, and left ventricle. This just reiterates the same last point that in the fetal circulation, you have high PVR, you have low SVR. And when the baby is born and takes its first breath, PVR dramatically drops, SVR dramatically increases, and that ductal right to left shunt that's supporting the fetal circulation goes initially bidirectional, then left to right, and eventually the PDA will close. So when we put this together, this is a nice picture from Satyan's group in Buffalo, who's now at UC Davis. You can clearly see you have a rise in PVR and a sudden drop highlighted in blue, and a rise in SVR and a continued rise in SVR after birth. So when we're talking about persistent pulmonary hypertension of the newborn, it's really talking about a situation where the PVR does not drop after birth. And what we've learned is that there are different mediators of pulmonary vascular tone. We can see in the fetal stage that there are vasoconstrictive mediators that keep the PVR high, things like CO2, things like reactive oxygen species, oxygen mediators, endothelium. And then after birth, there are vasodilatory mediators that open up the pulmonary vasculature and lead to a decrease in your pulmonary vascular resistance. Now, all of this is really best understood with the mediators of pulmonary vasculature. And this will come back when we talk about some of the treatment options. You can see that there are mediators in the pulmonary arterial endothelium, so in the airway, and in the vasculature, and then there are mediators in the airway, kind of smooth muscles. There are the nitric oxide CGMP mediators, highlighted by A. There's prostaglandin CAMP prostacyclin mediators. There's rho kinase mediators, endothelial toxin 1 mediators. So all of this are all helping to make the transition from the pulmonary vasculature that's constricted to a pulmonary vasculature that's dilated. Now, kind of moving on, I want everybody to understand the different phenotypes of neonatal pulmonary hypertension. There's early or acute pulmonary hypertension or pulmonary vascular disease. It usually occurs from birth to the 1 week of age. It's a delayed adaptation of lung circulation. You can have severe hypoxic respiratory failure. There could be RV dysfunction, and there could be a relationship between under or maldeveloped or even maladapted. The second phase is with chronic or late pulmonary hypertension or pulmonary vascular disease. This occurs weeks to months. You have high levels of respiratory support, you have evolving RV dysfunction, and this could even persist beyond the ICU. And it's most commonly found in our preterm population. And then there's sustained pulmonary hypertension or pulmonary vascular disease. There's newer literature coming out of work from Oxford and Wisconsin looking at older children who were born preterm who could have persistent elevation of pulmonary hypertension, changes in RV pressures, relationships to blood pressure, exercise intolerance. So when I break it down into kind of early, neonatal pulmonary hypertension, I think about it in terms of that relationship to the mean pulmonary artery pressure. What affects the pulmonary vascular resistance? What affects pulmonary blood flow? And what affects pulmonary capillary wedge pressure or left heart disease? So looking at it in relationships to a maldeveloped pulmonary vasculature, you could think that there is a primary and secondary causes. So for example, with primary, you might have pulmonary hypoplasia. You might have trisomy 21, our classic congenital diaphragmatic hernia. You can have secondary causes. Again, CDH fits in both of these causes. There could be a relationship to placental dysfunction. Now, the most common cause of early neonatal pulmonary hypertension is when you have a maladaptive pulmonary vasculature, most commonly seen with RDS, meconium aspiration, air leak syndromes, sepsis physiology, and perinatal asphyxia like hypoxic ischemia encephalopathy. And then don't forget about the pulmonary venous congestion. You can have evidence of increased pulmonary blood flow acutely with AVMs, left to right shunts, and you can have LV dysfunction that can present with acute pulmonary hypertension physiology. It's also important to understand the late causes of neonatal pulmonary hypertension. And again, put it in the context of pulmonary vascular resistance, pulmonary blood flow, and pulmonary capillary wedge pressure. So if you put it back in that scenario, you could have maladaptive pulmonary vasculature with increased PVR. Again, it can be genetically related. So this is in the late pulmonary hypertension phase. You could have a maladaptive phase. The most common is going to be what we see with prematurity, BPD, chronic lung disease. You have a maladaptive pulmonary vasculature with persistently rising pulmonary vascular resistance. And then finally, the other common is when you have too much pulmonary blood flow, like what we have in our PDA that Dr. El-Koufash spoke about last week. And then you can have increased pulmonary capillary wedge pressure. That could be seen in children who develop pulmonary vein stenosis or mitral insufficiency or left heart failure. Now, the risk factors can really be understood in terms of what happens in the maternal period, the fetal period, and the neonatal period. And I've divided it here between early and late pulmonary hypertension. And this comes from one of the recent works we published in Clinics of Perinatology. But you can see clearly there's some race, there's chorioamnionitis, there are diagnoses like CDH and persistent and premature rupture of the membranes, neonatal causes that you have to think about, MAS, trisomy 21, so forth and so on. This will help guide you in your initial management, both in the early phase of pulmonary hypertension and the late phase of pulmonary hypertension. So when I think about the hemodynamic profile, I take it a step back. I want everybody to understand that the major components of the cardiovascular system are threefold. You have the heart that pumps, you have the vasculature or the transport network, and you have the blood or transport vehicle. Really, all of this is about the balance of oxygen consumption and oxygen delivery. And that really comes from work done by Dr. El-Koufash and Patrick McNamara, looking at what are the determinants of cellular homeostasis. What helps us bring oxygen to the different target organs? Well, it's the cardiac output, where the function of the heart is really to deliver blood to all the different target organs, with the function determined by how much is coming in, the preload, what's the resistance it's going out, the afterload, and the contractility of the heart, the intrinsic ability of that myocardium to contract. Now, when we look at it in terms of pulmonary hypertension, we're looking at the relationship between RV performance and the pulmonary vasculature as the target organ. So we want to understand what determines RV performance and how does it respond to changes in pulmonary vasculature or pulmonary artery pressure. So when we break it down, in pulmonary hypertension, for the most part, you have a rise in pulmonary vascular resistance, a rise in RV afterload, and initially the RV performance will meet that demands. It will access the functional reserve and hit some peak RV function. But ultimately, the right ventricle will not be able to meet the demand and ultimately fail. You don't die from increased pulmonary vascular resistance. What you die from is when the right ventricle fails. A nice picture by my colleague, Dr. El-Koufash, shows that there are different stages of this process. In stage 1, they are coupled together, the afterload of the function. In stage 2, with a rise in afterload, RV function meets that demand, but changes in RV hypertrophy. In stage 3, you get dilatation, But ultimately, as RV afterload goes up, RV function goes down, and the right ventricle uncouples from its afterload. Now, my colleagues, Dr. Amish Jain in Toronto, put a nice picture out to understand this relationship with persistent pulmonary hypertension in the early phase. You'll have a rise in RV afterload. Eventually, you'll get RV dysfunction, as I just explained. Less output going out to the lungs, decreased RV filling, decreased pulmonary blood flow. Then you're going to have hypoxemia, acidosis, and VQ mismatch. As a result, you have right to left shunting with increased RV afterload, so less blood's going to the lungs and more blood trying to go out to support the systemic circulation, less pulmonary blood flow. Ultimately, less blood goes into the lungs, less blood comes back to the left side of the heart, your LV preload goes down, that leads to LV dysfunction, and ultimately you get systemic hypoperfusion and shock. So it's these three key factors: RV afterload, increased pulmonary pressure, RV dysfunction, and the relationship to systemic circulation. That's going to be the hallmark of how we decide to treat these children. Here's just a nice diagram showing the pulmonary contributors, RV afterload, RV function, right atrium, and the systemic contributors. We have our LA filling, LV function, and LV afterload. And why I break it down like this is because our treatment modalities will change based on which property is rearing its ugly head. So now we're going to shift kind of to the next part of the talk and talk about how do we assess cardiac mechanics or hemodynamics in neonates? How is it specifically focused for children with pulmonary hypertension? You can use cardiac MRI, cardiac CT, cardiac catheterization, and echocardiography. I'll speak mostly about echocardiography, but touch upon some of these other interesting modalities. But first, just to take a step back, every evaluation of a child with pulmonary hypertension, early or late, begins with the clinical evaluation and diagnosis. Oftentimes in the early phase, you have hypoxic respiratory failure. We're looking at maternal risk factors, perinatal risk factors. We're looking at resuscitative measures, thinking about pre and postductal SATs, and X-ray, imaging, blood gas evaluation. I'll speak more about this towards the end, but I don't want this piece of the puzzle to be lost on anybody with assessing hemodynamic evaluation. Now, this table comes from recent clinics of perinatology by Lauren Ruas, looking at diagnostic imaging approaches of neonatal pulmonary hypertension. As I mentioned, both acute and chronic pulmonary hypertension are early and late. The first line screening and diagnostic modality is echocardiography. When would you progress to cardiac catheterization? In each phase, it's when your treatment or your intervention is not responsive to the initial therapies. With chronic pulmonary hypertension, for example, with BPD and prematurity, it might be used to confirm diagnosis, assess severity, look at contributing factors such as pulmonary vein stenosis. Some centers use it when they start to add multiple pulmonary vasodilatory medications. Cardiac MRI is emerging. Not every center can handle it. And cardiac CT falls in that same bucket. But both modalities in the future will provide very helpful assessment and diagnostic markers of pulmonary hypertension. So the old way, the conventional way, is really to look at qualitative assessments and quantitative estimates. We're looking at measures of RV morphology, so enlargement, hypertrophy, dilatation. The traditional measures look at septal wall flattening to give us a sense of RV pressure. People look at the degree of shunting, and then they look at the relationship from RV systolic pressures to LV systemic pressures. So this is a nice way to think about it, but I want to offer two other ways to help you assess pulmonary hypertension. The first comes from an article recently published looking at comprehensive echo assessment of pulmonary hypertension. I like to think about it in terms of measures of RV systolic function, measures of RV diastolic function, measures of RV afterload, so that's pulmonary vascular resistance and pulmonary pressures, measures of RV morphology, and how does that interplay with shunts, and then measures of LV function or systemic circulation. I will go into depth a little bit on some of what is seen on the screen here, but when I stop and think about it, what I'm really saying to you is four major things. I am looking at how do I assess the severity of pulmonary hypertension? How do I assess the right ventricular pressure or the pulmonary artery systolic pressure or mean pulmonary artery pressure? What is the degree of RV performance? What's happening with the shunts at the level of the PDA, the atrial level, and if there's a VSD? And then what's happening with LV performance? Because ultimately the goal is to provide systemic circulation. So as we go throughout the rest of the talk, I want people to start to think about it in terms of severity, RV performance, and shunt physiology. So let's start with septal wall configuration. So why do we use the septum? There's some old data from Boston, 1983. They had 19 children who had RV pressures less than 50% and 17 children who had RV pressures greater than 50%. This was a simultaneous Doppler and echo study. And you can clearly see from this old graph that there was a nice correlation. So this mode was actually adopted, that you use the septal wall flattening as a measure of the degree of right ventricular pressures or pulmonary artery pressures. You know, it shows a nice relationship between the right and the left ventricle. It's the most common approach. There are several limitations, which I'll talk about. And I don't think it always accurately captures the full assessment of RV afterload, which is pulmonary vascular resistance, compliance, and pressure. So here's just an echocardiographic depiction. These clips come from both Dr. El Kufash's lab and Nick Evans' lab, where we're looking at the relationship of the right ventricle to the left ventricle. Here's a normal kind of left ventricle. But when we're talking about septal wall flattening, we're talking here the septum is flat. Now the translation basically comes to you can have a normal curvature, a flat septum, or bowing into the left ventricle. And based on some okay data, that gives us an assessment if that relates to subsystemic, systemic, or suprasystemic pressures. So that's the history of the septum. The next one I want to kind of take a peek at is a measure called eccentricity index. So that gives a more quantitative approach to assessing the degree of the septum and its relationship between the right and the left ventricle. Normally, it should be 1. The relationship of the perpendicular to parallel measures of the left ventricle should be equal. But when the septum is flat, you can clearly see that the measure will be greater than 1. Here, it's 1.6, and some data suggest that if it's greater than 1.3, that's indicative of pulmonary hypertension. So moving on, how can we assess pulmonary artery pressure other than looking at the septum? Well, you can actually look at the TR jet, or you could look at measures called the pulmonary artery acceleration time, looking at measures either between the right atrium and right ventricle, or measures between the pulmonary circulation and the right ventricle. So let's take a little bit deeper dive into that. So a few ways you can assess the tricuspid regurgitation jet velocity. You could look at an apical 4-chamber view, and this is highlighting the measurements between the right ventricle and the right atrium. You can clearly see this is a normal echocardiogram here with blood going from the right atrium to the right ventricle. And when we look at a degree of tricuspid regurgitation jet velocity, we see there's high pressures in the right ventricle and there's a blue jet going from the right ventricle to the right atrium. And that indicates elevated pressures in the lungs, assuming there's no degree of any pulmonary valve abnormalities. Now, the data, you can also look at this from a parasternal long axis view, looking at the kind of the inflow between the right atrium and right ventricle. This is just another mode to look at it. So again, we did the 4-chamber view. We're doing the parasternal long axis view. Here's a normal flow in figure B, and then the TR jet, which you can see in figure 8, shows a regurgitation back from the right ventricle to the right atrium. Now, the history of that, again, comes from the early 1980s. Simultaneous Doppler and echocardiographic studies in adults found a correlation between Doppler and cath-based studies. Now, this is good. However, more recent data, which I'll show you on the next slide, shows some abnormalities in that. So when we're talking about the TR jet, we're talking about putting it either in the modified Bernoulli equation to give us an assessment of PA pressure, or a recent Abbess formula from the early 2000s giving us an assessment of pulmonary vascular resistance. Now, recent work in BPD children from 2008, with almost 12 years, and then work from our group, now it's almost 8 years ago, looked at simultaneous Doppler echo and cath measures and showed that at lower pressures, the TR jet actually was predictive of the pulmonary artery pressures or the RV systolic pressures. But at higher pressures, you can clearly see in the red dots, it spreads out from the line. It may not be as reliable. So when we put it all together, there are several potential benefits of using the TR jet to assess the pulmonary artery pressures, but it may not be reliable at higher pressures. It relies on using a modified Bernoulli equation with several assumptions, and it doesn't always capture the full changes in RV afterload. So several groups have moved away from using the TR jet and have focused on looking at RV systolic time intervals. So that's looking at a measure between the right ventricle and the pulmonary arterial circulation. This comes from a parasternal long axis view, looking at the RV outflow tract. You can see this is nice function, the LV, the RV. And when you look at it in comparison to a dilated pulmonary artery, here's abnormal RV function, you can actually assess the Doppler flow through that RV outflow tract in figure B is normal, and figure A is abnormal. And we can see a Doppler flow pattern that is completely different. So this pattern, which is highlighted on this next screen, looks at a relationship of the flow pattern leaving the right ventricle. And if there is low pressures, highlighted in figure B, you have a nice symmetric parabolic flow. But in figure A, where you have increased afterload, increased pulmonary vascular resistance, increased pulmonary artery pressure, and decreased compliance, you have a quick upswing. The pulmonary artery acceleration time will be less. This is corrected by RV ejection time to account for heart rate. And you can clearly see in figure A, it's morphologically different than figure B. And this has been clearly shown in recent work with Dr. El-Koufash and my own lab, where we have correlated these measures on the x-axis, pulmonary artery acceleration time, with measures by invasive cardiac catheterization, PVR in figure A, pulmonary artery compliance in figure B, and show that there are nice correlations, really highlighting that measurements of RV systolic time intervals provide both measures of RV afterload, both pulmonary vascular resistance and compliance. When we put it all together, are these the best measures? Are they better than the TR jet? The data is still out there, but it provides another way for us to assess pulmonary artery systolic pressure. So I've showed you measures of septal configuration, looking at TR jet, and now RV systolic time intervals. Now, I want everybody to understand that it's not only about grading the severity of pulmonary hypertension, it's also about the relationship to the right ventricle. The right ventricle is a complex tripartite structure, has an inlet component, an apical trabecular component, and an outlet component. And when we think about RV morphology, we're understanding that when we're looking at an apical four-chamber view of the heart, we're looking at the relationship between the left side and the right side. And what we see here is a normal figure over here on the right, but on the left, you can see the right atrium and right ventricle are dilated, and you have a bowing septum. So you have changes in your morphology. Another way to look at morphology is look at the parasternal long axis view of the heart, where you can look at the relationship of that right ventricle directly to the left ventricle. Shown here in these figures, you have a normal right ventricle, a normal left atrium going into the left ventricle and the outflow tracts. But you can clearly see here in the figure on the left over here that the right ventricle is completely dilated and the function is decreased. So two different ways using echocardiography to assess the impact or the pressures in the pulmonary system and its impact on the right ventricle morphology. You can use areas or linear dimensions. Both have limitations, but both are pretty good at giving you an assessment of RV morphology in relationship to elevated pulmonary pressures. So this is a nice video that Dr. El-Koufash shared with me, really giving you a good way to assess ventricular function, both on the LV and the RV. What we can clearly see here, there are three unique ways. The first way is looking at a change in cavity dimension from its largest cavity dimension in diastole to its smallest in systole. And I'll give examples of that. That's ejection fraction or fractional area of change. The second approach is looking at a change in a single point from kind of a baseline during end diastole to a new position at end systole. So this is the tricuspid annular plane systolic excursion, or TAPSE, or tissue Doppler velocities, or tissue Doppler imaging. And the more novel, newer way is looking at a deformation or a change in the actual shape of the myocardium. And you'll see in this figure from a baseline shape in diastole to a new shape at systole. So again, here is kind of the summary: a change in cavity, a change in displacement or velocity of a single point, or deformation imaging of a segment. So you can clearly see the first way is with fractional area of change. This looks at a change between end diastole and end systole. And basically, some of these measures have had good correlation with MRI determined RV ejection fraction. We have normal, feasible, and reliable measures in term and preterm infants. There are some limitations, but this is just one way to assess RV function in neonates with pulmonary hypertension. Another more commonly used way, which has a little bit more data in terms of validation, is looking at the tricuspid annular plane systolic excursion, really looking at how the tricuspid valve has an excursion from end diastole to end systole, and measuring that change either in M mode on the bottom or apical four-chamber on the top provides a nice, feasible, and reliable measure of LV longitudinal function. There are some limitations, which I can go over more in depth later, but it is proven to be a pretty good measure of RV function. Another measure that people have looked at is tissue Doppler imaging. Again, this is looking at a change in point. You can do this at the right ventricle, the septum, or the left ventricle. There's differences between children and preterm. But what I like about it, it provides a measure both systole and diastole, both early and late. There are normal values that exist in premature infants as well as neonates, and there is ongoing work looking at this in pulmonary hypertension. And finally, a work that Dr. El-Kufash and others have really pioneered, looking at right ventricular strain. A lot of data emerging in children, in neonates, term and preterms. It's angle independent. It gives you a really nice assessment of RV function, both systole and diastole, and really nice data looking at its relationship to afterload, preload, and contractility. So when we put this all together, the final piece of the puzzle, I've showed you severity of pulmonary hypertension. I've shown you assessment of RV performance. Now I want to look at atrial level and shunts, as well as shunts at the PDA. It's important to know where the flow of blood is going. This comes from a subcostal view of the heart. We could look at the relationship between the right atrium and left atrium. And in a case where you have pulmonary hypertension, you might have right to left flow or bidirectional flow through kind of a bulging intraatrial septum compared to no flow through the intraatrial septum in figure B. And that gives you a really good sense of what's going on at the atrial level. Now, the other area to really focus on is what's going on with the PDA when it is there. So there are many different ways to look at the PDA. This is just a high parasternal view of the PDA. And it'll be interesting to understand, again, this video comes from work by Dr. El-Kufash and the T&E Echo website, but understanding how the flow of blood is going. Is it going left to right from the descending aorta to the pulmonary artery, highlighted in this first video? Is it going right to left, highlighted in this second video, from the pulmonary artery out to the aorta? Or is it going bidirectional, highlighted in this third video? So understanding the shunt physiology is the third component when we're talking about pulmonary hypertension. So recent article in Journal of Pediatrics put out a nice comprehensive evaluation of neonatal pulmonary hypertension and divided it into three classes: class 1, class 2, and class 3, where you can see there's severity, look at the TR-jet, septal wall configuration, pulmonary artery acceleration time, measures of RV function, and then systemic perfusion. And this is evolving over time, where recent evidence has also looked at kind of what are the normal values, normal term, normal preterm, and what do the values look like in pulmonary hypertension. So these are extrapolated from all the different data sets that are out there, with ongoing work to really validate this in all of these different populations. So kind of with the last kind of 8 to 9 minutes, I want to talk about the management of pulmonary hypertension. I know there'll be many questions on this. I want to give you our viewpoint, how we approach it here in Boston. So we have an overarching theme. We want to correct factors that promote vasoconstriction. We look at it in 4 different modes. The first is supportive cardiorespiratory care. I'll get into that in a minute. pH targeted therapy, promote pulmonary vasodilation, things like oxygen and nitric oxide. How do we optimize RV support? And then if we have to use invasive interventions such as ECMO. So let's jump right into it. We talk about the supportive care. There's maintenance of adequate oxygenation, optimizing lung recruitment. All of that is geared towards oxygen as the first pathway in the mediators of pulmonary vascular resistance and pulmonary vascular dilatation to help us with pulmonary vascular dilatation. Correction of metabolic derangements, circulatory support, I'll show a nice figure as well. And finally, limit stimulation with sedation or muscle relaxation to limit the catecholamine release, which can cause pulmonary vasoconstriction. So when we think about it, the baby presents with hypoxic respiratory failure. You look at clinical assessments, you look at your resuscitative measures. When we talk about supportive care, we're talking about optimizing ventilation and oxygenation, setting what our target goals are for the pHs, for the CO2s, for the PaO2s. We're talking about sedation. We're talking about correction of metabolic derangements, glucose, CO2, calcium, acidosis, correct your hematocrit. Thinking about infectious evaluation. Are these children at risk for sepsis physiology that can cause further pulmonary vasoconstriction? And then our cardiovascular goals. I'm going to talk about this in the next slide. Then we move on to you're suspecting PPHN physiology. You're going to evaluate for congenital heart disease. You're going to make sure there's no other cardiac, pulmonary vasculature, or lung causes of hypoxemia. And then you're going to grade your severity of pulmonary hypertension. And that was the first part of the talk. You're going to look at severity of pulmonary hypertension, the degree of RV function, and then the relationship to the shunts and LV performance. You'll move on to then thinking about your pulmonary vasodilators, nitric oxide, fracture and inspired oxygen. And then you ask yourself every day, what are your PPHN goals? To have adequate pulmonary blood flow and adequate systemic blood flow. So with PPHN, early pulmonary hypertension, you want to increase your SVR, lower your PVR, lower your pulmonary artery pressure, and optimize heart function. So keep that in mind when we think about all of the different inotropic medications I'll talk about in 2 slides. So when we talk about pulmonary vasodilatory therapy, we're thinking about it in terms of the mediators. How can we affect the nitric oxide pathway, the cGMP pathway, the cAMP pathway, so forth and so on. So the starter of all of this is oxygen. You turn the oxygen up, that will stimulate every pathway you see below. The next kind of 2 pathways are inhaled nitric oxide. These 2 pulmonary vasodilators have the most evidence and research out there, both with term and preterm infants. Then you could use something like sildenafil, which can block the phosphodiesterase 5 pathway and promote vasodilatation. There's the prostacyclin pathways, example of Flolam. There's milrinone, which affects the phosphodiesterase 3 pathway, breaking down the cAMP to ANP. And then there's bosentan, which is not really used in the acute pulmonary hypertension phase, more in late pulmonary hypertension. And this comes from work from Amish Jain, almost now about 6 years ago, really highlighting where the current evidence lands, looking at oxygen and inhaled nitric has kind of large RCTs in meta-analysis. Sildenafil has kind of a small RCT, and everything else is really just kind of case series and case reports with evolving evidence that's coming out more recently. Here are 2 great references for pulmonary vasodilators. So again, it's really looking at the mediators and the pathways that we speak of. And what I'd like to kind of finish with the last kind of 4 minutes is look at what are our goals? How do we use some of these cardiovascular or circulatory support medications? How do we approach it on a day-to-day basis? So that's where I'm going to leave this up for a few minutes, let people kind of digest it. This goes through all of the current drugs that are out there. It talks about at the bottom, the receptors, both alpha, beta, dopamine, talks about what a vasopressor does, inotropy does, chronotropy does. But the goal here is for people to understand what are the effects? What are your goals? Your goal is increase SVR, lower pulmonary PVR, and optimize heart function. So if you just start to look at some of these medications and you put it into the context, well, if you look at norepinephrine, it raises SVR more than PVR. It lowers your PA pressure based on some small animal studies and small studies in neonates, but it has no effect on your cardiac function. So if on echo you suspect cardiac dysfunction, norepinephrine may not be the best drug. It may help, but it doesn't affect the optimizing heart function. Now let's look at epinephrine, for example. Epinephrine will raise your SVR. It'll increase your mean arterial pressure. It helps with contractility and function, but it doesn't have any impact on your pulmonary artery pressure. So if a baby has a heart rate greater than 170, for example, and has good function of the heart, then you may be inclined to use something like norepinephrine over epinephrine. Norepinephrine has been better shown in the pediatric literature for septic shock. So again, you're going back to what are your three questions that you're asking yourself? A medication like hydrocortisone, that's probably going to be a second or a third line medication. It increases SVR, increases your mean arterial pressure, has no effect on heart function, and has no effect on pulmonary artery pressures. And you can go use the same philosophy as you go down. Milrinone increases contractility, decreases PVR, but it has a negative effect on SVR. So you really have to ask yourself, when is the optimal time to use it? Newer literature coming out with vasopressin, where it helps increase your SVR and it lowers your PVR, but again, no impact on heart function. So you might want to avoid vasopressin if you have severe LV dysfunction because you don't want to necessarily raise your SVR. The take-home point here is there are many different medications, and what you need to do is look at this cutoff. You have to have cutoff values in your mind of when you might consider a second line or third line agent. You don't want to be on a dopamine of 20 or 25 and then start to add in your second line agent. So again, the questions become back, how do you assess SVR, PVR, and optimize heart function? So you put it back into the third step. We talked about severity of pulmonary hypertension. Now the second step is optimization of RV performance. You want to understand what is contributing to the preload, the contractility, and the afterload. And to optimize that, you want to optimize preload. You may need fluid. You may need PRBCs. You want to augment RV systolic function. You want to know, is the baby normotensive? Are they hypotensive? What their heart rate is, and what the appropriate modality is to assess that and then diagnose it, and what are the therapies. And then you want to reduce RV afterload. We talked about the different pulmonary vasodilators, oxygen, inhaled nitric oxide. We talked about things like milrinone and vasopressin. And then you want to think, do I need to supply the systemic circulation? Is prostaglandins an appropriate temporizing or palliative approach? So there are some special considerations I won't spend that much time on, but basically with prematurity, perinatal hypoxemic ischemia, and infants of a diabetic mother, it's important to understand the mechanism. So let me just give you one example. In perinatal hypoxic ischemia, there's an impact to the LV function, an impact to RV function, and then there's a secondary impact to the pulmonary vascular bed. So how you manage that needs to be tailored around optimizing LV function, RV function, addressing the acidosis, the ischemia, the hypoxia, and then addressing how you manage the hypoxic pulmonary vascular bed. Other examples are sepsis physiology, twin-to-twin transfusion. Dr. El-Kufasha has done a lot of work on this, knowing that these kids are at risk for pulmonary hypertension. And then the Down syndrome population is also at risk for pulmonary hypertension, both in the early phase and the late phase. So here's just an example of how I work through it. So you have hypoxic respiratory failure and hypotension. You want to optimize ventilation, recruitment, supportive care. You're going to get an echo. Let's say you've assessed for pulmonary hypertension. If there's no pulmonary hypertension, what are the other causes? Cardiac, pulmonary vasculature, lung. You find pulmonary hypertension, you want to understand the severity of it, pulmonary artery pressures, the degree of RV performance, and you want to understand the relationship to the LV function, the shunts, and the systemic perfusion. The goals, remember, are increase SVR, lower pulmonary vascular resistance, lower pulmonary artery pressure, and optimize heart function. You might start with oxygen and inhaled nitric. You might have a good response, a poor response. You might look at systemic blood pressure. If it's normal, you might consider something like a milrinone to decrease your PVR. If it's not normal, you might think about epinephrine to raise your SVR, support your RV function. And then there's always the consideration for systemic perfusion and prostaglandins. So if you use the tools that I've shown you, you'll be able to really approach it. So why is this important? Well, the impact of PPHN in term infants, there is not an insignificant amount of mortality. You are at an increased risk for all of these morbidities I've written on the screen, developmental delay, feeding problems. In the pulmonary hypertension population, recent work by Martina Storr out of UCSF showed you have increased mortality, increased readmissions, increased ED visits, and your post-ARDS mortality is really high in these children. There's even an impact on chronic pulmonary hypertension in the preterm population, changes in both long and short-term neurodevelopmental outcomes. I'll skip the next study. And finally, the thing that I just want to highlight to people is how do you screen for pulmonary hypertension? This is more focused on the late pulmonary hypertension. So we know that children who are born preterm, less than 32 weeks, have some degree or at risk for some degree of pulmonary hypertension. And all of the different algorithms out there have said that if you're still on some degree of respiratory support at 36 weeks, you should consider screening for pulmonary hypertension. So I just put this algorithm out there. I'm not going to go into depth. I'm happy to share it with people. But the basic idea is identifying the risk factors, perinatal, postnatal, even the late risk factors, looking at pulmonary hypertension, trying to understand the relationship between the severity of the pulmonary hypertension, the RV function, and then the shunt physiology, understanding that echocardiography in your clinical exam is the first step into the paradigm. In other situations, you could use cardiac cath. In more advanced centers, you can use MRI, CT. And remember, the goal is to provide a comprehensive information regarding preload, afterload, contractility to really understand the contributions of pulmonary vasculature, lung physiology, and cardiac physiology. And I think with that, with 11 minutes to go, I think the take-home message for me is really understanding how we use echocardiography, the predictive modeling, how we develop screening, hemodynamic multi-imaging, and then establishing what I call a cardiopulmonary team at each level to really help with the assessment of these unique children. And with that, I'd like to say thank you, and I'm happy to answer any questions.
Okay, thank you very much, Phil, for a excellent and a very comprehensive talk about pulmonary hypertension. I have a couple of questions coming through, but I thought I'd start by asking you a couple of questions, if you don't mind. You touched upon the various causes of pulmonary hypertension, and of course, for the initial management anyway, you need to tailor your management to suit the initial underlying cause. What do you feel is the role of surfactant in certain diseases that do end up causing pulmonary hypertension?
Yeah, that's an excellent question. I didn't have time to talk about it, but I just created this one slide. So surfactant therapy doesn't appear to be effective with primary pulmonary hypertension. So that's that idiopathic pulmonary hypertension. However, it should be really strongly considered in patients with what we call parenchymal lung disease, so RDS, meconium aspiration. And then some of the data has really shown that early administration of surfactant and optimal lung recruitment is associated with improved outcomes and reduced risk for the need of ECMO or death. I think more work needs to be done on the use of surfactant, but I think if you were to clinically suspect RDS, meconium aspiration, where surfactant could be helpful, then I think you should utilize it.
Okay, just a follow-up question. Do you think, are there any situations where surfactant might be harmful in the setting of pulmonary hypertension?
Yes, another great question. I think, and this goes back to the role of echocardiography and advanced hemodynamic assessment, there are times with congenital heart disease, for example, an Epstein's anomaly, where you don't want to decrease your pulmonary vascular resistance and necessarily create what we call the circle of doom. So I think in some of these congenital heart lesions, it might be an opportunity where surfactant is not indicated. And then again, the data doesn't really suggest that there's any benefit with primary pulmonary hypertension, so that black lung.
Thank you. There's I suppose emerging data showing the potential benefit of vasopressin in cases of pulmonary hypertension that are certainly resistant to early management. What's your view on the use of vasopressin? I certainly don't have a lot of experience with it. We haven't started using it regularly. I know it was being used a lot more regularly during my time in Toronto, but that's not something I regularly consider um, in my patients anyway.
No, that's a great question. I think it goes, I'll answer the question in two parts. It goes back to what are your goals? It goes, increasing SVR, lowering pulmonary pressure, and optimizing heart function. I think there's a role for vasopressin. I know Patrick McNamara's group in Iowa has started to use a little vasopressin, sometimes with milrinone, but there's not a whole lot of data. Most of it is case series that exists out there. I think if you have an echocardiogram and there's no evidence of heart function, then vasopressin could serve a role to increase SVR and lower your PVR. It's really the only drug that has that combination. There are some side effects with some hyponatremia, but if there's any evidence of LV dysfunction, which Afif, you and I have both seen sometimes with coarctation or other causes of LV dysfunction, vasopressin could actually be harmful. So I think it comes with the comfortability of the center that's using it. But again, it goes back to what are you trying to accomplish with that medication? I think over the years, somebody will try and do maybe an RCT or a more rigorous study of vasopressin in neonates. I for sure have not used it in the preterm population. I've used it a little bit more as a rescue medication in the term population.
Okay, thank you. We have a question here coming through. What do you think about use of nitric oxide in extreme preterm infants?
Great question. Almost was going to anticipate that. The party line, as most people know, it's not FDA approved in the United States under 34 weeks. Some data says it doesn't change the outcome. Some other data says it could be more harmful than good. I think it goes back to kind of what you're looking at and what the physiology is with the preterm population. From my experience, when you have a term baby who has some degree of pulmonary hypertension and you settle on using oxygen and nitric oxide and you have your echocardiogram, they typically are going to be on the nitric oxide for some period of time, a day, 2 days, 3 days, and you're slowly going to wean it as you optimize SVR, PVR, and heart function. In the preterm population, in the early period, there are such rapid swings with their transitional hemodynamics with the PDA, with RV function, RV afterload. If you find that a baby is responsive to nitric oxide and you think there's early evidence of pulmonary hypertension, and I think there are studies that up to 2 to 8% and sometimes up to 60% in infants with RDS can develop pulmonary hypertension. It's not a child where you put them on nitric oxide and walk away and come back 12 hours or a day later and wean their nitric oxide. This is a child that you may have to consider getting a repeat echo in 6 hours or a repeat hemodynamic evaluation because they are going to wean off the nitric quicker because their PVR could potentially drop faster. So I think if you're going to use the nitric oxide in the preterm population, although it's not FDA approved, you have to have a close, vigilant watch over the hemodynamics.
Thank you very much. And on the same line, I suppose, there's another question about the use of milrinone in extremely preterm infants. I don't know if you want to take that.
Sure. I think to answer the milrinone question, you just have to go back to the physiology. So milrinone acts on the sarcoplasmic reticulum with calcium homeostasis and metabolism, and then in the lungs and in the periphery will end up causing vasodilatation, and in the heart it will cause contractility, enhanced contractility. In the preterm population, the sarcoplasmic reticulum and the calcium homeostasis is immature. So we don't really understand how milrinone will necessarily act, if it will stay around longer, if it will be eaten up sooner. There's ongoing evidence to look at that. I have used milrinone in the preterm population. I've used it in the management of PDA and post-ligation cardiac syndrome, but I don't use a typical bolus of the milrinone because sometimes it can cause more harm or it may not have the same impact. There is some evidence with the use of milrinone in the HIE population and how does that impact children who are being cooled and under therapeutic hypothermia. So again, similar to my comments with vasopressin, I think we have enough evidence to help us use it in a term population, but how it's used in the preterm population, you just have to be cautious. And again, you have to ask yourself, what are you trying to accomplish with the milrinone? If you're trying to enhance contractility and then use it to also lower your pulmonary artery pressure, it may have some role. There are no studies that I'm aware of that uses milrinone in the management of early pulmonary hypertension in the extreme preterm population. It's more in the term population.
Thank you. One final question. There's a few people asking about the role of sildenafil, and there's a couple of questions about, you know, a lot of listeners practice in countries where nitric oxide is not freely available. So I suppose the role of sildenafil in that context, and then the role of sildenafil in the context of poor response to initial nitric oxide.
Yeah, both excellent questions. You know, the meta-analysis that's out there that talks about the 77 patients, and I think there are 5 or 6 studies, and 3 of the studies were done in countries where they did not have inhaled nitric oxide. There was a beneficial role of the use of sildenafil in the management of these children, both the term and the preterm infants. So I think there is a role. I think we need to study it more. I think in the role where either you're unresponsive to nitric oxide or you're trying to wean from nitric oxide, there is a few studies where sildenafil has been shown to be useful. One study where they utilize it in the cardiac intensive care units in the United States is that when you're trying to wean off nitric, some advocate for giving a one-time dose of sildenafil 30 minutes before they shut off the nitric to avoid kind of the rebound hypoxemia. I think truthfully, more data is really needed on the use of sildenafil. I think you have to be careful if you're going to use it IV versus enteral. A lot of centers that I know will start it at half the dose 3 times a day or half the dose once a day before titrating it up. I think you just have to understand what are the effects of the sildenafil in both the preterm and the term infants in causing a drop kind of in your oxygen and everything, and improvement of your oxygen. So I think there is a role going forward. I think the studies that are out there give us hope, especially in the countries that don't have access to inhaled nitric oxide.
Okay, I think we'll finish up here. Phil, thank you very much for an excellent talk and for a thorough answering all the questions really, really well. On behalf of everybody here, I'd like to thank you for giving us the time to deliver this talk. So thank you very much.
Thank you all.
Good night.
Good night.
Good night, everybody.